we'll go ahead with the keynote address now, and our keynote address is going to be given by Dr. Prakash Kumar Chowdhury, and Dr. Prakash is from Bangladesh. He's a consultant ophthalmologist, phaco and LASIK surgeon, and he's a fellow of phaco surgery from India itself, and he's MSDO and MCPS. And he's going to talk on my worst case scenario.
Greetings from Bangladesh. Thanks to everyone. So I will share some unwanted experience during my phaco. This was a 50-year-old man having soft cataract with limbal dermoid in the right eye, and there is no history of ocular trauma, and there is no significant astigmatisms, and the left eye is normal, and we plan for cataracts phaco with under topical anesthesia, and according to on the patient's demand is trifocal lens. So after making the 2.4 millimeter main ports, an optimum size, the axis is being created with a 26 gauge band hydrocannula. Then in the AIOC, a small band hydrocannula, the hydrodissection is being performed. And every time after injecting the fluids, the nucleus is decompressed. Now you can see there is a subluxations in the subincisional area which was missed during the preoperative period. So I go ahead for the sculpting, and note here my bottle height is very low, infusion flow is very low to avoid undue pressures on the capsular bag and to take care of the remaining zonules. And my corresponding aspiration flow also very low, only 18 cc, and vacuum also 18 millimeter mercury. And the sculpting is going on, and usually my preferred technique is a four quadrant nucleotomy, but to avoid undue pressure here I am doing the chip and flip techniques, and before take out my phaco probe I am injecting the dispersive body through the side port to maintain the stability of the chamber. My next plan is to put the CTR ring to stabilize the capsular bag, and now I'm checking the presence of inhibitors to inject in the thiamsulfone acetonide. So I can see there is a bitters is there. So by swiping the bitters to the side port with the spatula, I proceed for educate vitrectomy with high heart cut rate 4000, and my inflow is very low, and corresponding also I have very low aspiration flow rate. And again I'm injecting the dispersive to the side port before take out my irrigation handpiece, and then I proceed to remove the remaining nuclear materials. So with a very low inflow and low infusion pressure, I am taken out by the remaining fragments. Now we can see the pupil size is come down, and this is the time. So I am injecting the cohesive OBD under the iris to lift up the iris margins. My plan is to use the iris hook over here so that I can see the cortex very clearly, and with the using the bimanual IA, I am removing my cortex. And the advantage of the bimanual IA, as the irrigation and aspiration handpiece are separate, they maintain the anterior chamber greatly. Again, I am injecting the dispersive OBD every time to maintain the stability of the chamber, and according to patient's demand, I proceed to implant the trifocal IOL over here, and trifocal IOL is being injected. Now the iris hooks are removed, and one bite is taken, and the remaining the OBD is removed to the bimanual eye. The case is over, and the side port is hydrated, and you can see this is the first post-mortem day. The cornea is clear and everything is okay. Then the second case, so this was a small non-dilating rigid pupils. So injects intracameral mydriatis to improve the dilatation pupils. Now I am injecting the cohesive dispersive OBD followed by cohesive OBD, but the pupil is not dilating, which is a strong indications of the rigid pupils. So after AVIT, that is STS pupilloplasty, I am using BHAXing over here as a pupil expansion device, and after injecting some the BX is placed in the anterior chamber above the iris, and after injecting the cohesive OBD under the iris, the BX ring is tucked. They're using a 23 gauge forceps through the side ports. Now I chips a good circular, and here I am using the tip and blue to extend the bitters. And the advantage of this technique is it does not allow the anterior chamber and pupil to get collapse, and optimum size rhexis is being created with the 26 gauge band hydrocannula. Again, hydrodissection is I am performing. Usually I prefer Akahosia small band hydrocannula, and the advantage of this cannula, I can go up to the equator. And now the sculpting is proceeding, and with the low bottle height, low infusion flow. Here I am using the stop and chop technique to divide the nucleus into multiple fragments. And here also I am keeping my bottle height is very low, and phacoemulsification is complete with the routine using the torsional ultrasounds and uninterpreted burst modes. And I'm using the bimanual eye, and before taking out the handpiece, I'm injecting the cohesive OBD, because now my next plan is to implant the IOL. So during implant the IOL, during forward movement the IOL, you can see over here there is a fracture between, and the optic is fractured between the mechanical obstruction. So to exchange this, I first inject the dispersive OBD above and below the IOL to take care of endothelium capsules and posterior capsules, and I'm cutting the lens into the 3 pieces, holding the lens firmly with the left hands, and through and through I cut the lens into 3 pieces. Then each 3 pieces is taken out very gently through the main port, as you have seen earlier in the earlier presenters. And after being that, a new IOL is being implanted, and BX ring is disengaged and taken out to the main ports. In this case, this was a routine cataract, and after making side port, the dispersive OBD is being injected, followed by cohesive OBD and ideal soft shell technique. Again, optimum size rhexis is being performed, hydrodissection is being done, and the nucleus is managed. I'm dealing with the nucleus. Here I'm using the stop and chop technique, and nucleus is removed in a routine way. And if nucleus is taken out, at this point I noticed there is a rhexis at 6 o'clock, but when and how this rhexis was occurs, I could not figure out. So I inject dispersive OBD through the side port to maintain the stability of the anterior chamber, to prevent so that the tear cannot extend further. And with a very low bottle height, low infusion flow, and low vacuum and low aspiration flow rate, I am aspirating the remaining cortex. The bimanual eye, here my bottle height is only 60 centimeters. And now you can see there is a PC tear through and through oriented in the same plane. And so now I have rhexis tear and at the same time PC tear. So before taking out, I am injecting the dispersive OBD through the side port before take out my irrigation handpiece. Now what will be the next plan? Should I implant a single piece IOL in the back? If I can do that, it will be more tricky, physiological, but by doing that, I may extend the PCRAN and I cannot get enough support to place the IOL in the back. Another option I have, that is a multi-piece IOL in the sulcus, which is a bit easy solution for me. So I decided to implant the single piece IOL into the back. So before unfolding, I rotate the lens and I place the lens in the anterior chamber cautiously. I didn't put it in the back. Then through the side port with the dialer, I put the haptics first into the back, and through the other side, again the same technique, same principle. I am pushing the another haptics into the back. You see the IOL looks in good positions, and I inject the pilocarpins to constrict the pupils and inject triamcinolone acetonides to see the presence of any bitters. The bitters face was intact, there is no disturbance of bitters. So anterior chamber is washed with the BSS. Pupil looks everything looks okay. and external main port and side port is being hydrated. And this is the first POD. The intraocular pressure was 14 millimeter mercury and cornea is very clear. Thank you so much for watching this video.
Thank you, sir. Thank you. So you have seen this again, the use of Caesar, you have to expand the lens, which is very common, not so uncommon like before days. So we have to be very aware of managing the complications, and we should have all types, especially circus fixated lenses we should have in our OT, because there is a PCR, you cannot fix the single piece lens. We should avoid it, but we are doing it because we are not having single piece